Hello, everyone. Firstly, thank you so much for coming in and joining today's session. Uh, I'll wait for around 5-10 minutes more before I start the session. So, this is uh, going to be a series of sessions where we are going to discuss surgical videos and how to perform surgery. We will have something called as virtual OR. You will be at your own nice sweet spot and you'll be enjoying the feel of operating theater, operating room. You'll come to know how to do the surgeries, what are the tips and tricks, and that too from many of the star surgeons. So, as we proceed to our series, today's introductory session that is going to be endoscopic sphenopalatine artery, cautery, or ligation. I'll tell you the difference why I'm using the word cautery and not ligation. Um, as I said, that I'll wait for around another 5 to 10 minutes before I start. And meanwhile, what I'd like to add is that if anyone has any questions, please enter in chat box, and there you can just keep on asking questions. That is number one. Apart from that, we will take the questions later on at the end of the session, as it happens in the other webinars. The next session is going to be in month of April. This is the first session, and we'll have sessions every week, every month, sorry. So the next session is going to be by surgeon, Professor Vitor from Portugal, Lisbon. Then followed by, we'll have session in month of May, which will be by Vikas Acharya or Juan Maza from Spain. And then we have got uh, Professor Anne Bidstrup from uh, Denmark. And then we also have many people from UK and across the globe. I'll just wait for 5 more minutes. Okay. Meanwhile, I'll keep on talking. We have got multiple suggestions that we got, and they're quite interesting. We had sent out a list of the topics and suggestions you wanted to get covered, and we have got fantastic topics. And I would like to say that most of these topics are going to get covered. We are going to go from the conventional to non-conventional surgeries, normal to revision surgeries, and we will have a lot of surgeries, irrespective of the age, pediatric and adult surgeries as well. Many of the surgeries you would have seen and you would have performed multiple times. But however, when they are coming from some very good international recognized surgeons, you'll understand the small bits and pieces, the differences, and that will eventually help your practice. We will try to cover definitely maxillectomies in further session, because nowadays maxillectomies are becoming more and more common and popular. And that is one of the reasons why today's session is going to be sphenopalatine artery, ligation, or cautery. Before I start, I just want to introduce myself. My name is Dr. Paresh Naik, if you can see the screen. Yeah, my name is Dr. Paresh Naik, and I am trained in rhinology skull base. And if anyone has any issues with screen, or if the screen is not moving, please feel free to interrupt me and talk. So I am a consultant. I practice mainly skull-based surgeries along with also thyroid and rhinology. I've done my fellowship and training from mainly from Birmingham under Professor Shahz Ahmed, and after that, I have done fellowship in head and neck as well, and I did my diploma in France. I was a consultant, locum consultant in UK, and now I am practicing currently in Mumbai. As I said, after the session, you can ask questions. I'm going to add this. The next session is going to be in April, and that is by Professor Vitor from Lisbon, Portugal. We'll keep you updated regarding that. I'm going to proceed with our session. Now, today's session, Sphenopalatine artery cautery or ligation. Why is that difference? This session is not going to have any slideshows or anything. It's going to start with a video directly. It's a completely unedited video. And why am I using the word cautery and not ligation? Because there's a difference. Ligation, am I audible enough? You can drop a message on the chat. So why, good, thanks, Chandni. So why cautery and why not ligation? Now understand, sphenopalatine artery, one of the major blood vessels of the nose. It supplies almost 80 to 90% of the nose, and it is quite thick. Okay. So when we are trying to ligate, the usual way of ligation, whenever anyone says ligation, it is what happens is we are thinking of a tie. Someone is going around the vessel and we are tying it. It doesn't happen so over here. You cannot tie it. You have to either clip it. Okay. The clip is very good. However, the clip has to go around it. Let me explain what I mean. If there's an artery, the clip has to go like this. Okay, then it works. However, the posterior part of the sphenopalatine artery is the back wall or the front face of the sphenoid. Okay, so whenever you're clipping, the clip many times doesn't fix well. The second thing that happens is that from the sphenopalatine, there are branches coming out, and clipping can miss one of the branches. I'm going to start with the video. So we have a young, around 14-year-old girl who presented with epistaxis. And following that, is this seen? All good? So this is completely unedited video. What I'm going to start showing you is that it's an endoscope, 0-degree endoscope, and we are going in the nose. This is an adult gentleman that we are performing surgery on. The pediatric one, we have a separate video. So as you can see, this is a gentleman who had torrential nosebleed. So most common causes of nosebleed in an adult is someone who is on blood thinners. Okay? Someone who is on aspirin, someone who is on clopidogrels, and that is what they want for their life, or they had multiple procedures, heart surgeries, or stents. And when you make a phone call to your colleague and you ask them, can they stop your voice is breaking. Okay. Just a minute. Am I audible? It's clear? Okay. I'll start again. So when you ask your cardiologic colleagues or consultants, asking them that the person is having epistaxis and we need to stop blood thinners, and they're going to say, no way, we are going to not stop that because it is essential for them. So that is when we need to do a sphenopalatine artery cautery. And this is the usual thing that you will see. The patient had multiple episodes of epistaxis. You're going in the nasal cavity and you don't know what to do. So as I speak, I'm going to add few tips and tricks of the procedure. Number one, when you're going in, you will see that the nose is almost always congested. It's very difficult to pass a camera. Any epistaxis, we have to look into the nose thoroughly. And that is when we need a proper examination under anesthesia. If we are going inside the nose, there's hardly any space, so we have to decongest the nose. What are the different ways of decongestion?
اروح عادي.
What are different ways of decongestion? One thing is that you can use a patty, use some adrenaline and go inside. Some people prefer using merosil, that they cut merosil and they go inside and they put it over there. Two things I'll tell you with my experience, what I've understood, that rubbing over the mucosa doesn't help. Rubbing induces inflammation. It will, in fact, cause bleeding. Using just a patty, and if your anesthetist allows you, then 1 in 10,000 or 1 in 5,000 concentration is good. You have to tell your anesthetist that this is something which is important and you're not going to infiltrate. It is the patty that is going inside. Sit topically, that will help to decongest. The other thing is that try to trim the nasal hair. It is actually important. And this is what you see if the nasal hair is not trimmed. And trimming the nasal hair gives us a good view. One more thing that I would like to add is that whenever you're trying to trim the nasal hair, use scissor rather than blade. These small things actually improve your surgical outcome. The scissors you can coat with any ointment and trim the hair so that the hair doesn't fall in the cavity. As you can see, I have used some ointment and applied. So when I'm cutting with the scissors, the hair sticks on the scissor. Meanwhile, the patties are sitting inside and they are acting, it is getting decongested. The next thing that we have to understand is that what if the blood pressure is high? And what if it is not possible to use the patties? In that case, you don't have an option, but bribe your anesthetist. Tell them that you'll give whatever you want. You want to use at least 1 in 50,000 adrenaline. 1 in 50,000 adrenaline, that will help to act very well. The issue with the longer concentration or the higher concentration is that it takes slight more time. It takes more concentration. So ask your nurse not to squeeze the patties, to give you dripping wet patty. Okay? And that's when you can put inside and go. Usually when we are packing the nose, we prefer to pack it in when they're getting induced or when we can proceed inside. But however, in cases of epistaxis, we cannot pack blindly. Now see this magical difference. Can you see this? Before you could not pass the endoscope. Now in real time, and this is a real time video, in less than 5 minutes, see how beautifully the mucosa has got decongested. In fact, there are some areas it has got blanched. Okay, so that has allowed us to get a good view and a good examination under anesthesia. One small thing that happens when there is a deviated septum is that when our scope is going inside, we can injure the nasal septal mucosa, and that can also trigger bleeding. In this particular video, what happened was that there was some bleeding from the anterior part of septum as well. I'll show you. And whenever we are introducing the endoscope, you hit that part, it causes bleeding, and it gets covered with blood. So that can cause a bit of annoyance. In this video, I'm going to talk more of a practical aspect than what is the anatomy, where it is, how to do it and all. Give multiple washes. Any nose surgery, please give wash. The wash will help to clear the clots. It will help to clear the mucosa. It will clean your lenses. It will actually make the mucosa very healthy looking like. Now see, just by nasal trimming, how has our view changed? So if you can see, we have not done anything major. In 6 minutes, we have trimmed the nasal hair. We have decongested with just patties, and look at the outcome. It's great, isn't it? So going beyond, we are going further and the area has got decongested. Many people like to infiltrate the
இங்க
uh,
வந்து ப்ளஸ் பண்ணோம்
area. Can someone please
இங்க
mute their mic?
கிளம்புறேங்க.
That will be helpful. Thank you. As we proceed further, this is the other side of the nasal cavity. It's always nice to examine the other side because whenever we have epistaxis, many times the patient says that it started from one end and proceeded to other. Usually the bleeding can be from the back end or the bleeding can come just from the front. It's necessary for us to identify. I'm going to take it further. Now, this is where you can see I'm trying to infiltrate. I'm going to pause it for a bit. Why I'm going to pause it? Look at the anatomy over there. Number one thing is that if you're very lucky, the middle turbinate will get decongested. Also, the inferior turbinate will get decongested. Many times, if they're not getting decongested, we have to use a Frere's elevator to lateralize the turbinate. Lateralizing the inferior turbinate gives us a good working space. Okay? A good working space is necessary. The other thing is that there are two ways of doing sphenopalatine artery cauterization. One is by doing middle meatal antrostomy, then identify the posterior wall of the sinus and then proceeding to elevate the flap. Here I'm going to show you the other side. What is the other way? Without doing MMA, that is middle meatal antrostomy. Why I don't want to do an MMA? Because if the maxillary sinus is good, the mucosa is good, why do I want to injure it, right? You work minimum so that the function is retained. This is a spinal needle. I'm infiltrating, as you can see, is getting infiltrated. The spinal needle is quite long and it helps to infiltrate well. Make sure that you are aspirating. Why you are aspirating? Because there are going to be branches. Those branches, we don't want to go intra-arterial and aspirate. This is a key area, I would say, starting from the tail of middle turbinate to the choana. Whenever we are elevating the flap, that is the area where we have to elevate. Going further inside, after infiltration, it's always nice to place a patty in. Why? Because the infiltration can act locally, and also you have triggered some injury over there that can cause some bleeding, and the topical patty will help to resolve. As we are going further, another important bit that you need to understand is that while suctioning, try to avoid the direct suctioning of the middle turbinate. Why am I saying specifically middle turbinate? Middle turbinate is highly vascular. When you're going inside and if the middle turbinate gets injured, it's going to bleed a lot. And if you try to cauterize that, it is going to lead to a lot of crusting. Over here, what I'm trying to understand is that I'm trying to see if I can move that anterior part of the septum aside because it will allow me to go inside. One thing I can notice while doing that is that there's a small blood vessel, that's a tear, and that can cause bleeding. I'm doing nothing, just using a bipolar. Keep the bipolar at a lower end. How low can you use? Keep it at 8 or 10. You have to use a couple of drops of saline between the prongs and they act very well. Or if you don't want to use bipolar, you can use gobleter or you can use laser. We are going to have a session on laser again in one of those. Many people ask, is it safe to use bipolar on the septum? What if it can cause septal perforation? Understand that you are not going to burn the whole area. The second thing is that the nose has got very good blood supply. And the other side of the nose, the flap is preserved. Hence, the chances of necrosis are less. Whenever there's an injury on both the sides of the cartilage, that is when you'll have more of chance of septal perforation. After doing this cautery, you have to make sure that you're not injuring the surrounding area. Also, after the surgery, you have to ask the patient to use Vaseline to apply over the nose. Why? Because we have used cautery. Number two is the surgery itself can cause a lot of dryness in the nose. So when you're signing a consent form, you have to make sure that you write that dryness is one of the important bit that can happen. Why am I doing this? Because the patient has also enlarged turbinates, and there are some areas where the patient was bleeding. So turbinate is again one of the important site where the patient can bleed. Now, many people can ask that we are cauterizing on both the sides, and what are the chances of having adhesions? There are good chances of adhesions, but if the both opposite one of the surface is only involved, the chances is less. We have infiltrated, then going forward, then further, we have to elevate the flap. How do we do that? You can use 11 number knife or you can use a sickle knife. The area that we have to address is from the tail of the inferior turbinate to middle of middle turbinate. Going inside, what you can see over there is this area which is completely decongested, infiltrated, created a nice plane. Okay? I'm going to take it a little bit forward. You can see a sickle knife. This sickle knife, I'm making an incision from where? Half of the height of middle turbinate, coming down to the inferior turbinate, the tail of inferior turbinate. Most important part, where am I going to make the incision? You have to palpate and where the mucosa of the maxillary sinus, the medial part of the maxillary sinus, medial wall of the maxillary sinus ends, and where the bony part starts, you have to make an incision there. What if you make an incision on the ostium or just behind the ostium? No, don't worry, nothing is going to go wrong. The whole idea is that while elevating the flap, we need a hard surface where we can put our instrument inside and raise the flap. After putting incision, I'm putting patty in. As you can see, my use of patty is a lot. And this small step, it doesn't take more than 10 seconds, but this small step makes a massive difference in doing the surgery. We have finished the whole surgery in under 30 minutes or 34 minutes. And in fact, we have hardly used suction over here. There is no bleeding. It's all because of decongestion. Okay? Using that patty, we can put inside the flap, like how we do septoplasty. You feel that bone, you can see that bone, and try to elevate it. The action has to be a scooping action. Same like how we are elevating a Haddad flap. Go up, down, rather than going in one particular direction, creating a tunnel. Once you have done that, I'm using a Cautel's elevator, and you can elevate. There's a high chance of bleeding over there. When there is a sudden bleed, don't do anything, just pack again. Wait for some time. Using suction, you can see I'm using suction not directly on the mucosa. The patty is placed and the suction is above that. We are using Savlon solution over here because our endoscope sheath was not functioning well. That's why we have to take the endoscope out and dip it in the Savlon. The other thing is that I'm using the suction to elevate the flap. You can use a suction elevator, very good instrument. You can use a plain suction as well, or you can just use an elevator. If you're using the suction, make sure that you're using a patty on top of it. Once you have got a good view or a field, we can now try and elevate the flap further. What is our next landmark? Crista ethmodalis. Okay. That is what theoretically they say. But crista abdominalis is absent in almost 30 to 40% of patients. Now, when you're elevating, you can see I'm going from inferior to superior. Why inferior to superior? Because we don't want to directly elevate the vessel and cause a tear. Gently elevating, there is hardly any bleeding over there. If there is bleeding, you can just put a patty, give a wash, and wait. You can see that's the plane over there trying to elevate. The mucosa of the maxillary wall is maintained. The mucosa of the maxillary sinus is maintained. When we are elevating from the inferior aspect, we have to stop when we reach the curvature of the posterior part of the medial maxillary wall. Why? Because that's our endpoint. Going slightly superior, we can see a big, thick artery, a vessel. Can you see that? That's the big vessel over there. And that's very thick. It's a big, chunky blood vessel, Sphenopalatine artery. In 9 to 10% of the cases, the Sphenopalatine branches inside the foramen. That becomes a tricky situation. Most of the branches are outside. If it is inside, it becomes more and more tricky. So I'm trying to elevate more further because I have understood and trying to go further. And as we can see, as we move further, the reason I'm trying to elevate further is if there is one more branch which can be seen. Taking this further, again the patty is placed. Once the patty is placed, what I'm trying to do is that I'm trying to remove a bit of the bone, the crista. How did I do that? Is by taking a lux, and the bone, which is anterior to Sphenopalatine foramen, is quite thin. You can just hold it, twist around, and it will break, as you can see. Hardly anything. You don't need to use drill. You don't need to use anything. This is good if you want to make sure that if you want to cauterize the vessels as well, the branches as well. Going further in, you can see the artery. This is a chunky artery. Can you see that? And that's the big vessel that we have to deal with. Now, the biggest challenge over there is going beyond. And that's where I have, say, Sphenopalatine artery cautery. You use a ball probe, try to go behind the vessel and bring it forwards. What happens is that by doing that, you are taking the vessel out from the bony wall and taking care of the posterior margin. The next thing that happens is that the ball probe helps gently to probe. It doesn't cause an injury. Once you've taken the vessel forward, that is where you can use a bipolar. Now you can see I'm using a bipolar over here. There are different types of bipolar. You can use an endoscopic bipolar. You can use a non-endoscopic bipolar. The whole idea is that you have to go above and below. When you're using a bipolar, I start usually on 15, then I escalate further. You keep a suction in the other nasal cavity. Why? The suction, the smoke, will go in the choana and will get sucked out. You can see I'm cauterizing it. And after cauterizing, many will feel, wow, we have done our job. The vessel is sorted out. Okay? But no. The blood vessel wall is quite thick. And even if you're seen, this kind of cautery will not guarantee complete collapse of the vessel. Going further, again, we can cauterize. There's a lot of charring that happens, and that's why we use a wash to remove the charring. That gives a good idea. when you're using a bipolar, which is a handheld bipolar, you can use a bayonet-shaped bipolar. The bayonet-shaped bipolar works very well. It goes inside. If not, the skull base has got, there are separate bipolars. Suitor has got really good bipolar, which opens in a very delicate fashion, and you can go in a lot of skull base areas. After dealing that, trying to cauterize. Now, one must say that how long I am going to do that. So remember, this patient had 3 episodes of torrential epistaxis, that his hemoglobin dropped by almost 3. And after doing the surgery, if the patient comes back again with epistaxis, what are you going to think about? So you have to be dead sure that the vessel is taken care of. Okay? So how do we make sure? We cut the vessel. By cutting the vessel, we see the lumen. Is the lumen completely gone or not? Here's the endoscopic scissor going inside and trying to cut. So here, that's the reason I have to be dead sure that I have charred it or cauterized it. As I said, I start with 15 or 18, then I escalate to 20. Okay, you can keep it 22 as well. If you use a lot of bipolar in that area, there can be a lot of dryness of the nose. But that's fine to have dryness of the nose. They can use olive oil nasal drops or Vaseline, and that can take care. Many patients require cauterization of posterior part of the middle turbinate as well. Why? Because there's a branch which splits before the foramen and goes behind. Even after using the bipolar so much, you can see that it's a targeted treatment. We are just targeting that area. We are not going anywhere else. The vessel shrinks. It shrinks so much, but we have to make sure by cutting it. You can leave it at this stage. There is no harm. Okay? There's no harm. But it is just one of those things that if you cut it and if you see it's not bleeding, it gives you a peaceful sleep. And also, if you get a call at night that the patient is bleeding, you're not that much worried because you have seen that you have taken care of the vessel very well. Going further, what kind of scissors can you use? You need to use endoscopic scissor. There are nice Kasam scissors as well, or Dura scissors, which are quite delicate and you can go inside. There are the scissors to the right side and left side and can be used to cut. After cutting it, again, I bipolarize it. Now, if someone asks me, did the patient bleed again? I said, no, the patient never bled. But yeah, patient did have dryness of the nose, and which was taken care with Vaseline or olive oil nasal drops. This is a real-time video, and these are the issues that you face. There can be smoke. Smoke can cause hindrance in your vision. So assistance work to take care of the smoke is very important. The sphenopalatine artery, cautery, or dissection is very important in many sinonasal malignancies as well. Also, when you're doing skull-base surgeries, many times, you need to address that. Patients with torrential epistaxis, this is the ultimate treatment than doing embolization. I'm cutting that. After cutting, going all the way till I feel the front face of the sphenoid going over there, raising the flap, and you can see there is no bleeding at all. The vessel has been separated completely. I'm going further to back wall, and there are certain branches that can come out from the tiny foramen and taking care of those. So if you're asking me, am I aggressive in this surgery? Yes, I'm aggressive in this surgery. What if I would have used a clip? Well, the clip would have stayed, would have got dislodged, never know. So this is slightly better in cases where the patient had a lot of bleeding, epistaxis, and is something that you want to take care of. The video is going to end soon. You can start writing down the questions and ask further. So how do I close it? In any this kind of surgeries, I use give a lot of wash. Why a lot of wash? Because after giving the thorough wash, you are taking the crust out and the chance of infection are less. I use ointment. I use Abgel. Abgel, you can soak it with tranexamic acid or just a bit of adrenaline and you can place it over there. Uh, After that, do we need to do it on the other side? Well, if the patient has bilateral epistaxis, yes. If it is unilateral, you don't need to address the other side. Do we need to close this flap? No, you can just leave it over there. The Abgel works very well. After 2 to 3 weeks, it's good to do an endoscopic examination and have a look. I have taken care of the anterior part of the septum also because there were a lot of injury while passing the camera. And remember, the anterior part of septum is mainly uh, the blood supply is not from sphenopalatine artery. So that is something we'll have to take care of as well. Thank you. Any questions? We also plan to discuss few sessions on case presentation. We don't have any cases for today, but if someone has any question or anything, please feel free to drop a message in and see. So we have got first question is, in case of refractory bleedings, what is your approach? So I'm expecting that refractory bleeding I'll talk about both kids and adults. In case of refractory bleeding, in case of kids, um, uh, you need to understand that the most common bleeding is from the anterior part, and that is when looking inside and just a silver cautery is more than enough. If they're having further more bleeding episodes, we need to do an examination thoroughly. In case if this surgery bleeds again, what are we going to do? The next thing is you have to address and check the IMAX. It's a very drastic surgery to go inside and clip the IMAX. The other thing is you can do an angio. The angio will help us to see from where it's bleeding. Bleeding from this, if at all, it's going to be torrential. That means some kind of blood vessel has got retracted and it has opened up. So if there is a further bleeding, you need to understand if the bleeding is in small quantity. If it is in small quantity, just ignore or tell them, reassure, it's going to be fine, don't worry about it. If it is a bowl of bleeding, then what you need to do is that you need to see, get either angio or take the patient to the theater. If it's bleeding from the same side where we are operated, we can cauterize. If you're not sure, you can do an IMAX ligation or cautery as well. Any more questions? When do you advise the patient to start irrigation? Immediately. Immediately. Nasal irrigation is nasal dressing. That's a very good question. So in such cases, the crust, because remember, the patient is going to have dryness of the nose and crusting will generate infection. So nasal irrigation is actually going to help to take the crust away. And that is going to help us to keep the nasal cavity healthy. The second most important thing, I did mention that after 2 to 3 weeks, we have to pass a camera inside and have a look. The nasal irrigation is going to help you a lot to clear that crust. So to answer that, when do you start? Immediately. So maybe after a day or so, because by that time the gel foam has started acting and we just want 24 hours for the topical hemostatic agents to act. Next question is, gel foam to be placed medially or lateral to the flap made? Okay, I'm going to ask a question. What is wrong in placing on both the sides? So you place medial to the flap, it will take care of any of this flap injury. and you place lateral to the flap, which will act like a packing. Okay, so a flap going on one side, on the other side, it will just take care of it. Like if you do pituitaries, where do you keep the abgel? You keep on the both the sides of the middle turbinate. Why? Because it acts as nice packing. In which cases, the next question is, in which cases do you do a biopsy of the mucosa? What's your experience with that? Fantastic question. Very good. Nasal biopsy. So that is the session we are going to have in month of June is HHT and Osler-Weber-Rendu syndrome. Okay. Or when the patient has got associated with autoimmune conditions. In those cases, a nasal biopsy is necessary to understand the blood vessels. And if it is a medium size or small size vessel disease. So in those cases, we have to remove the mucosa and send for the histopathology. So what are those cases? The patient usually presents with nasal bleeding and nasal crusting. Okay. Not only that, you have to find out if the rheumatoid RA factor is high or ANCA factor is high as well. It is supposed to be in a multidisciplinary format. You have to talk to your pulmonologist and also your rheumat friends and get along. In those kind of cases, sphenopalatine artery cautery along with the biopsy is going to be helpful. Dr. Sura has asked, what solution do you advise the patient to irrigate with? Pre-packed or homemade? So usually nowadays, what is happening is that when you get a box of any solution, they give some sachets, okay? They can use those sachets. The problem happens when the sachets get over. And that's when the ghost comes into picture. Those sachets are not taken care of by insurance. If you are working in any government supply like NHS, they were not supplying it, they were not providing it, or also they are very costly. If you're asking the patient to irrigate twice or thrice a day, one packet will last for a week. That's it. So what we ask them to make homemade solution. What is a homemade solution? I just tell them that it's like baking a cake. Okay, in half liter of water, you take a teaspoon of soda bicarb, teaspoon of salt, and a teaspoon of sugar. Sugar? Yes. So mix it, and you use it. So I usually advise patient, you make a 1 liter of solution in the morning, make this recipe, and you use it throughout the day. That's it, 24 hours. So even if they don't have like other things, even if they use just basic soda bicarb, a pinch of soda bicarb, that is more than enough. The water needs to be boiled and brought down to the normal temperature. Not to use cold water, not to use very hot water. The cold and hot water can stimulate the sinuses if you're doing a sinus surgery, and that can cause pain as well. Okay. Thanks for the nice comment, Dr. Roy Stephen from KIMS. We have got really good people want to know about DCR, skull-based surgeries. We do have a lot of skull-based surgeries coming up still. We are trying to keep this as once a month session. We don't want to overburden with other things going on. Once a week or twice in a month becomes a lot. We are going to have session on biologics as well. Stay tuned. Thank you for this is a 40-minute session and we have crossed 40 minutes. Thank you for attending and thank you for being there. Please, you can send emails if you have any suggestions. Thank you.